Hi, everyone. We're just waiting on Dr. Johnson, and then we'll get started. He should be here in just a minute.
All right. Hope everybody's doing well. Appreciate everybody taking time today to continue our conversation about the reopening of school. Appreciate our doctors for joining us here, and we'll share more about them momentarily. Jenny, I'll let you just kind of go through any key information in regards to the process for fielding questions.
Hi, everyone. Thank you for joining us tonight. So the way that this is going to work is Dr. Johnson is going to go through a presentation, and after the presentation, we're going to open up for question and answer. The way that we'll do the questions, since we've got a large group, is you'll submit them in the chat box, and I will read the questions to the group. And tonight we have Dr. Woods, Dr. Adams, and Dr. Hendricks with us. So they're here to answer medical questions. So specifically, if you have questions about the medicine and the data piece of our reopening plan, this is the time to ask them. So thank you.
Excellent. So I'm going to share my screen here. All right, so we have with us today Dr. Stephen Adams from Erlanger Health Systems, Dr. Charles Woods from Erlanger as well, and Dr. Paul Hendricks from the Hamilton County Health Department. Appreciate all three of you being here and your expertise as we've gone through this process. Just a few things we shared to set some context. Obviously, grace, choice, and fluidity are the three words that we've been really elevating, and the fact that we hope that you give us grace in this season, and that we are able to show grace, obviously, in return as everybody deals with this unprecedented moment. That choice is critical. It's important. We know for our families, and we've tried to be extremely sensitive to that. But then also understand this is just a very fluid situation. And so there's a ton of fluidity in regards to case counts and information that comes out, and how we respond to that makes it a challenge. March 13th, when we initially went out of school, we never would anticipate being out the rest of that semester, nor would we have anticipated, obviously, having this conversation as we're starting this year. But here we are, and we know this isn't easy. That we all must adjust to this new normal, and feedback, questions, and concerns are important. The engagement of experts is always important to us, but then we acknowledge that there's absolutely no playbook to this moment in time, and we're working through this together. This will be, I'm sure, articulated much even better than I can, but we're dealing with a pandemic that's, national, state level, then obviously here in our local community. And because of that, we thought it important to stand up a group of experts to help us make decisions. Several members of our team and members of our community, as well as teachers and parents and such, really helped us get to what we think is a solid framework for the consideration of the reopening of school. And these are the pillars that they use to make decisions. And so some of the key things we've been sharing is the gating criteria and the phases. Really broke the work into 4 phases. Phase 4 being that we're completely open. There's obviously at that point we think there's no spread, very, very little, all the way to phase 1 being that we are completely remote because of the spread that's in the community and the need to mitigate significantly. We really attempted to make the thinking visible, and we're pretty ambitious in this goal. I think in all candor, but thought it was really important to be as clear with the public about some of the things that we're looking at in regards to trying to make a decision. I will be really clear that at the middle of your screen are transition considerations, and although we've kind of set that active case count as a metric that we look at, also, there are many nuanced pieces to trying to make the best decision for children in our schools, and we understand that. So things such as average number of positive cases and daily hospitalizations, ICU, absenteeisms of teachers and students also are extremely important as we try to make decisions. We look at the cases daily, as the health department does a great job getting us that information, and obviously getting the public that information and trying to make our decisions. And we've started, as hopefully sharing on a daily basis where we are within the phases. And, really more important than anything, it's not as much about, making the public think that we're going to be in a different phase every day, because surely we're not. But it has been more about increasing the awareness of kind of how we use this framework to help us make decisions. Health and safety is something that obviously, as we get ready to transition here to the questions and the doctors, that we really want to spend just a moment on. Phases 2 and 3, we have and are requiring that face coverings be worn. Obviously, accommodations will be made as needed for special needs students and those that have medically necessary reasons. In K through 2, masks are not mandated, but we do outside of the classroom. We'll be requiring, because distancing becomes more and more challenging as K through 2 students are outside of the classroom. And so we want to be safe. Our goal is to stay in school and every step that we take to mitigate against, any spread or the steps that we feel are necessary because we absolutely want to do those things. This is a graphic that we've shared before. If we're not in mask, we know that if you're asymptomatic, you're not in a mask, and you interact with an uninfected person, the likelihood of spread is significant. And if we do what our experts tell us to do in regards to staying apart and wearing of the mask, we significantly decrease the propensity that there will be spread. And so just some key points there with face coverings: that they should cover the nose and the mouth. They should fit snugly. Made of washable materials and multiple layers. And then obviously we also, I just would note, not sure on this slide, that we'll support in any way possible with anybody that has difficulty with obtaining a mask. The CDC has made the recommendation around mask, and the call for face coverings may prevent the spread. We know that we're under a mask mandate as a county. And we again, our goal is to make sure that we ensure that we remain in school, and that's ultimately what we desire. Just a few notes here about preschool or early elementary school students. That we want to provide reminders on the importance of face covering, and we'll prioritize wearing them when it's difficult to maintain social distance. We do understand developmentally the challenges that exist and are very sensitive to that. And then, there's been some conversation about clear face coverings. Absolutely, for our deaf and hard of hearing students, as we work with them, and we will absolutely make those concessions. Then young students that are learning to read from a literacy construct and seeing the student, we absolutely will make those concessions as well as our ESL students and students with disabilities. We will absolutely work through that. really as well. The CDC at this point does not recommend the use of face shields for normal everyday activities as a substitute for face coverings. And so we are obviously sensitive to the guidance from the CDC. More than anything, it's really important. We think that we work together collaboratively as a community because we know that we can accomplish anything together to really be a part of doing what's necessary to stay safe. And we are and will continue to share this pledge that we're asking our community members as well as our students to make and take to stay at home if you're sick, to avoid getting too close to others, to wear face coverings, and everyone washing hands and staying safe. And so this is the acronym kind of broke down in regards to staying home if you're sick. If you are symptomatic in any way, you are uncertain about you being symptomatic, we ask that you stay at home. We because of the resources, supports, and the work of our teachers and leaders, we'll have the ability actually to be able to continue your learning, even if you're in a situation where you're a bit uncertain. If you think that to be the case, we absolutely want you to stay at home. And you see some key points there about if you have a temperature that's 100.4 or higher, or any symptoms of COVID-19, we definitely want you to stay at home. Avoid getting too close to others. And so distancing is something that's important to remember. I will tell you and acknowledge that it's tough to change this because, culturally, I think we're used to being in pretty close proximity to others. But the more, and I will speak as a father, the more you do as with your children in regards to helping them to remember that this is where we are in this moment in time, we will definitely work to mitigate the spread or a better chance of overcoming it. So definitely, we want you to avoid getting too close to others, and we'll be encouraging our students to do the same where possible. Face coverings, and we spoke quite a bit about those, but we know they are absolute must. And as we work to make sure that our children can stay in school and that our teachers and leaders, everybody is safe, and we can continue to operate in some semblance. And then washing of hands. There's been a lot of information out there about how to appropriately wash your hands for 20 seconds or more. And then also, we are making a commitment to absolutely do even more with high touch areas like doorknobs and light switches, and we'll continue in that effort. We are working through detailed guidance for positive or probable cases and contacts, as well as guidance for the clearance to return to school. That'll be available tomorrow, actually, by end of day. And so we are close on that. And then obviously we're aligning with the CDC and also working closely with our health department on contact tracing and quarantine expectations and all those responsibilities that we have. The health department has worked to provide testing throughout the county as a school district as well. Our ECS employees will have an opportunity for rapid testing to be available, results within 24 hours. And so, again, we feel the desire to do our part to make sure that our employees are in a great spot and aren't infecting others and are doing what they need to keep themselves safe. And so we're excited to be able to offer that through our one-to-one partnership and our health clinics that we have here on site. I've talked a little bit about the health department, but they will have a team. I'll let them speak to that here in just a moment. That will be leading the contact tracing, and we will work to assist them in that contact tracing or with that contact tracing, so that if there are any positive cases, and in the likelihood that there are, that we will get that information to anybody that has been in contact as expeditiously as possible. I shared this a little bit, but please know that our health department has done a great job of making testing available. You can visit health.hamilton.org or give them a call. You see the hours there. We encourage you to do that. I'll talk briefly about academics, 4 phases. Obviously, if we're in phase 2, which is the one that's most unique, Monday and Tuesday on campus, Wednesday through Friday, it's digital or blended or online, I should say, remote. Cohort B, Monday through Wednesday is remote. Thursday and Friday, you're on campus, and HCS at home, you are completely on campus. We've elevated this quite a bit, but this is a fluid situation. We're working through high touch areas. We are prioritizing our HCS at home students. Obviously, if you're in HCS at home, we ask that you stay for the duration of the semester. We will be providing PPE kits at every class level. Also, we learned this week the state will be as well. So we feel like we will be in good shape from a supply standpoint as well. We will be working with schools to provide supply kits at the school level. We'll make masks available as I shared. And the 12th through the 14th, we know will be an orientation orientation days, most likely an A day on the 12th, a B day on the 13th, and a remote day on the 14th. And then obviously our remote learning has signed up with over 25% of our students and families deciding really close to 30% that remote or virtual is the option for them. We have a frequently asked question document that is online. And we encourage you to take a look at that for additional information, www.hcd.org. And you'll see a reopening tab, and please feel free to access that. There's been a lot of conversation about final decisions being made for what phase we're going to be in. That decision has not been made. We're still working through that and understanding cases, because of the fluidity of the situation. It's our goal to make the best decision and to be able to stick in there with that decision as long as possible. So we will absolutely get there. All right, so I will stop sharing, and I'm sure that the questions of today for our doctors will appreciate you being here. Jenny is fielding those questions, and I'll turn it over to Jenny at this time.
Thank you, Dr. Johnson. So we've got quite a bit of questions today, and so what I'm going to do is prioritize the medical questions first, since we have these doctors with us to answer them, and then we'll get to the other questions. So the first question that we have is, does the school system or health department have access to the average number of days between testing and patients receiving results? Is that being considered in the phase transitions?
I'm not sure whether the school system has it. We have that data internally in the Erlanger Health System, and we certainly keep close tabs on it. And I'm sure Dr. Hendricks has data from the testing that he's performing.
Yeah, we've been trying to watch that real closely, and fortunately have been seeing the lag time narrow. Actually, in the last day or so, it seems to be down to about 48 hours. I'm almost nervous to say that, but I hope it continues. But we have seen a significant improvement in the lag time for testing recently. And we are keeping a close eye on that.
All right, our next question is about masks. And so this is from a staff member whose principal said that masks with an exhaust valve are not okay. And they're wondering if N95 masks with exhaust valves are effective.
The problem with exhaust valves is that what you're trying to do with the mask is prevent from spreading respiratory droplets around. They're very, they're fine if you're doing like industrial work or something, and you just are more trying to prevent from breathing things in. But when a lot of the advantage of a mask is if someone has the virus and is asymptomatic, doesn't realize they have it, the mask probably has more benefit in preventing you spreading that. And if you have an exhaust valve where your exhalation breath is going out into the atmosphere anyway, then it's defeating that purpose. So that's why the masks with the valves are really not ideal in this particular situation.
Thank you. So we've received several questions about this Harvard research that has been put out saying that schools should, I'll just rephrase the question. Why are medical professionals supporting the reopening plan with Hamilton County's new cases per 100 residents is 100K residents is more than 25? And I'm sure you're familiar with the Harvard study, but it's saying that if a community has more than 25 cases per 100,000 people, that schools should not be reopening. And so why are medical professionals supporting our reopening plan that doesn't use that criteria?
Well, I'll tackle that first, and Dr. Adams and Dr. Hendricks, feel free to jump in on this as well. I mean, this is one set of guidance that's out there, and we've discussed. Dr. Adams and I were just discussing earlier. what's the basis for those particular metrics? And there are more conservative ones, there are more slightly less conservative ones. And so this is certainly a very well thought out piece of guidance, but it's not necessarily based on a clear study. And it's certainly something I think that will need to be followed. I think the plan that the school system has developed with the phases and when to look at it certainly would take this into account, but it may not be the only piece of information to take into account, and looking at trends and things like that as well. So we're certainly look at it very seriously. It's not necessarily the only guide, but we're not discounting it, I would say, and we're still digesting this a bit as well.
Yeah, I would echo that point. The first thing that we need to emphasize is that the guidance will change through the year, and what our set points are today may be lower. And there's other physicians that are quite angry that we've been this conservative in our recommendations. So we're defending ourselves from both directions. I think flexibility, watching the leadership of our public health experts and adjusting as things occur are important. And there was a mention earlier about what are some other factors. Probably the most important one that's outside of this plan is if we get close to exceeding or meeting the capacity of our healthcare system in the region to take care of these patients, then all bets are off. And regardless of the number of active cases, if the healthcare system is strained, then we immediately have to rethink our plan.
I agree. I agree with both Dr. Wood and Dr. Adams. I think that's exactly right. I'd make it unanimous.
Every day we get some new bit of information that we put into the pile of all the other pieces of information, and just know we're actively looking at this individually and collectively to say, does this study change something? Does this set of opinions from a very respected, very highly experienced group of scientists change something we need to think here? So just know we're going to be keeping at this and be ready to move in a different direction if data come out that really say that we need to do so.
One thing, Jenny, I would, and we didn't have it in necessarily this presentation, but one point we always elevate about our plan, we say it's a framework. What we try to create is a framework. It's not a set in stone piece. And Keith and Colonel Brooks and Jen Bronson, the entire group that was a part of, really helping to lead that. We don't see it as a set in stone. So I think to the point that was said earlier, if we obviously learn through the medical professionals that something significant has changed, we're going to change, how we need to. I don't know, Keith, you may have something you want to add to that.
Yeah, yes, sir, Dr. Johnson. One of the things that, as we went into this, and one of the things that we talked to the task force about is, and we've sought a lot of feedback and through the process and made adjustments, as we were developing the plan. But it was, as we told the school board on July 2nd, the plan is not set in stone, and we're obviously, just as Dr. Adams, Dr. Wood, Dr. Hendricks said, we're going to learn more. And as we learn more, that's when we put ourselves in a position to be able to make adjustments. But we also want to be sure that as we're learning, we're taking guidance from expertise, whether that be our medical profession or if we're on the academic side, that we're always deferring to expertise.
So building off of that question, our gating criteria uses the active case number and a couple other factors. So can you talk about why those thresholds were chosen?
Those numbers are easily accessible. And, if I could have anything I want, I'd want to know how many patients are in the hospital 2 weeks from now, because that'd be a lot better way to know. But, that's an impossibility. So it's a little frustrating. It's not the best possible thing ever, but it's what is practical.
I think that's exactly right. That the information that you can get that is current, that is, on time and available is the best, and local, very local is the best to make decisions on. So.
Right, and we'll be looking at trends as well. So it's not one day. We'll be looking at running trends. Is it creeping up? Is it going down? Maybe it's at a higher point than we wish, but we're starting to see something edge down. And then, as was stated before, do we still have significant capacity within the hospitals in the region to handle more cases, should that be there, or should those come in? And then, as we get into this, we'll also find other things we can look at and monitor. We'll be looking at are there increasing illness rates amongst children who are in school? Are there other, what else is happening in the community? So we will have to look at all of these factors as we go forward. And it won't be probably any one data item that drives decision-making, but trying to look at lots of different things together and then balance a lot of other risks with that as well.
All right, our next question is, does the health department plan to increase testing?
We have a certain limit, just personnel and such. So right now, we're working hard at having testing available 7 days a week, in addition to the testing that's being done by other partners, by the hospitals and other private clinics and such. So I can't really say right now that there's a plan for adding additional testing. We're just trying to make it available on a regular basis at this point.
Say it's not necessarily directly related to the health department, but all of the health systems in Chattanooga are adding capacity. In addition, our vendors are adding capacity. We've added an interface with an additional vendor because we could get tests back quicker than what we had done with other vendors in the past. So I think another month or 2 months, and we'll see a big improvement in the testing situation. And it's not bad now compared to the way it was even a month ago. A month ago, I was very frustrated. I'm much happier today with the test availability and the turnaround than I was then.
Yeah, it's been a steady improvement over several months, but it's getting better.
All right, our next question is, why did the health department stop publishing the positivity rate? And there's just a general comment with this that some of the stuff that the state has done with publishing positivity rates is really helpful, and that it would be nice to have that for Hamilton County.
Yeah, I actually was aware of that question in advance. I'm not sure that we ever were publishing the actual positivity rate. It is a useful number. It's a difficult one to stay on top of, just because it really requires coordinating the negative tests and the positive tests and exactly when they were drawn. And you really want them very close together, because, if you compare positives in one time period with negatives in another one, then it's not helpful. I do know that we're working hard at, we've been able to markedly improve our ability to post the negative numbers as quickly as the positive. We've had obviously a strong focus on the positive numbers, that the positive cases, because those are people we really need to focus on and getting that out there. But we've markedly improved the availability of the negative numbers and are trying to get to the point where we can actually post that. But it's possible we put out some numbers very early on, but if we ever posted it, it was just on a very limited basis, and we've really not done it routinely. But we're trying to get to that point very, very soon.
All right, our next question is, why does the number of active cases fluctuate so widely? And there's an example earlier this week, from Monday to Tuesday, there was a significant drop of active cases. So could you talk a little bit about that?
And yeah, I've had texts about that change, and I noticed that too. And if you look at the number of active cases of the ones who are currently sick, and since the vast majority of cases of COVID-19 is a 10-day period after which the contagiousness drops off to almost nothing. So with some exceptions, it's kind of a 10-day period. So the patients the people who are kind of rolling off of being on isolation and therefore becoming resolved and no longer active, if you look back 10 days, you can kind of look at where they came from. And if you look back 10 days from the beginning of this week, we really had kind of a surge of patients. We had a few days there where we had several over 100. And so I think what happened is just that little surge we had 10 days ago, suddenly a bunch of them became resolved, got better. And this is not an automatic, in 10 days, we obviously are checking with these people on a daily basis. And so they're not considered resolved until we've actually been in touch with them and know for sure they are. So it's, it's a good number. It's a real number, but why that change happened there, it just looks like we had a large number of patients about 10 days ago. And then fortunately, most of them resolved and got better. And so we had a drop. And we've seen some flattening in our cases over the, knock on wood, but we've seen some flattening in our cases the last couple of weeks. So we're hoping that trend continues, and hopefully we'll continue to see the active case rate drift down.
And I'll echo that I was talking to people some physicians in Nashville today at Vanderbilt, and they have seen something similar in terms of flattening a little bit. So I'm hoping that continues. And for those of you who remember basic statistics in the term signal to noise, when we're in the middle of a pandemic and we have changing dynamics of test return timeframes and other things like that, and small surges and then changes in behavior with maybe flattening, you'll see fluctuations that may be real or may go up and down. And so we have to look at the trends and other factors that may be explaining that and just watch it carefully over time. But you may see some fluctuations that don't always make sense at first glance, but in a few days they may.
Yeah, absolutely.
All right, our next question is kind of two-part, and part of our team will answer it, but part of it is medical as well. And it's talking about airborne transmission with COVID-19. And just, I'd love for you guys to talk about the airborne transmission piece of it. And then the question is about how the district is going to address air quality in our school buildings.
Can we skip that one? So there is with most viral infections in children, we've known always there's been what we call a droplet or larger particle transmission. So a droplet is something that if someone sneezes or coughs and the particle hits your face or your skin, you can feel it. It's 5 to 10 microns or bigger, and aerosolized particles are smaller, and they stay and float around in the air longer. There's some evidence that there may be an aerosol component in some cases to COVID-19 SARS-2 transmission. It's not exactly an all or none aerosol droplet. And there are a lot of factors that can weigh into that, including how long you're close to someone, how close you are to them, their viral load, how much virus they're shedding, airflow characteristics in the room. So there are a lot of factors that go into whether aerosol may be a risk factor, and it probably almost isn't outdoors in most situations unless you're right in someone's face, but it may be in some closed spaces where people are together for half an hour or longer, maybe sometimes less, but significant amounts of time, and lots of generation of coughing, singing, things like that, possibly generating aerosols. So we're still, I think, collectively looking at this around the globe saying, okay, how much works, or what will work for this? And we also know that masks don't really prevent a lot of aerosol transmission, but they seem to be really effective in reducing risk of this infection. So I guess the short answer is we're not 100% sure. There's probably some aerosol risk, but probably not in all situations, and that the masks that we're using prevent a whole lot of the transmission.
That's absolutely correct. And it brings up a couple of interesting points, and one of which is that there's still so much we don't know about this virus. We're learning, things coming out every day. A new study comes out, and And we're learning, and it drives people crazy because they say, well, why did it change? And last week you were doing this and that. But it's just the fact that we're in the middle of this thing. The other thing about masks and droplets, I've seen people, online saying, well, masks don't work because the virus is this size and the mask is this size and the fabric. But the reality is, like Dr. Wood said, if the viruses were just floating around by themselves, yeah, they're extremely tiny, but they float on droplets of respiratory excretions, if you'll. And so, and the closer they are to your mouth, the larger they are. They tend to get smaller as they get out into the atmosphere and disperse and dehydrate. So wearing a mask isn't about stopping a naked virus. It's about stopping those respiratory transmissions that are full of lots of viruses. And this is why, a mask is really more effective at preventing the spread from the person to others. Although obviously, if you're up close to somebody, there's going to be some protection for the person wearing it too. So that's the reality behind it, is that it's those respiratory droplets. And he said there's some evidence that the virus may continue to float around on smaller and smaller aerosolized droplets. But this is once again why getting into rooms with lots and lots of people is problematic, and then why we see in so many cases come out of these mass gathering situations, and why we really prefer people stay in apart. And it's just feeds right into all the advice we've been saying about masks and social distancing and hygiene and everything else, and avoiding large groups. That's the science behind it right there.
One practical side is if you look now at what's happening in our hospitals today, where you may have a hospitalist or a pulmonary critical care specialist working as many as 80 hours doing nothing but taking care of COVID patients. And the sickest ones around, people who are coughing and spewing, people on ventilators, people who are getting nebulized breathing treatments, they're not catching COVID. And that's because when they go in the hospital in the morning, they put on a mask and they don't take it off till they get to their car. They go grab their food out of the cafeteria, sneak off somewhere and eat it. And I'm not aware of one of them catching it from a patient. In fact, I'm not aware of one of them having it. So
I'm sorry.
Go ahead.
I was gonna say there's a great story of like two hairdressers somewhere who turned out were both positive, and I don't remember the exact details or numbers, but they had like 140 clients over a week or two, but the clients all wore masks, they all wore masks, and no one caught it from them, even though they were turned out to be positive. I think it was St. Louis or somewhere.
Yes.
That was a case study reported out by the CDC that it works, like you're saying, Dr. Adams. So I'm sorry, I didn't mean to interrupt you there.
Oh, I agree.
Good.
All right, our next question is about the summer, and we know there's been some daycares and summer camps that have been in session, and they're wanting to know how many positive cases have been identified at daycares and summer camps, and have they been traced to outbreaks?
I'm sorry, I don't have
Yeah.
that detail of information, and I haven't heard of any large specific outbreaks here locally. We know in Missouri there was a big camp where there was a big outbreak this summer, but if there were some individual outbreaks, I don't have that information right at the top of my head.
Yeah, I'm not aware.
Yeah, I haven't heard of any in the pediatric infectious diseases circles either.
I think the only thing I could add, Jenny, is every Thursday, the county mayor convenes a children's cabinet, which has several outside service providers that are engaged in, summer camps and service for children, have been throughout the course of the summer. And in fact, the YMCA is represented on there, and they've been going since, the beginning of, the identification of it. And we've received great response and feedback from them as they've shared ideas and shared input. And I think to the point, they've not seen any spread. I can speak to, positive cases that may have come about. But we've received, again, great feedback and instruction and lessons learned from them as we consider open. I don't know, Kid, you might have some share. I know you're on those calls.
Yes, I just wanted to add, I can't speak to Dr. Johnson's point to every summer camp and daycare provider. However, in Hamilton County Schools, I did want to highlight that we have been running school-age childcare at 25 sites since the end of May. We also started, and I may be off on the number of sites. I think Dr. Robertson is on, and he might correct me on for school-age childcare. I know that there was also, we ran 25 sites starting July 13th for the Summer Reach program. And in both of those scenarios, school-age childcare as well as the Summer Reach program, where we're probably serving between the two, call it about 1,500 to 2,000 children, that we have not had reports of a positive test case from a child. And in fact, with Summer Reach, we had one confirmed positive case at a site, and that case was not associated with transmission at the actual site. It was an adult, and it was someone who had traveled the week before they started interacting with the Summer Reach program. So based on our own experience, which is anecdotal, not empirical data, but just anecdotal, we have not experienced with the school-age childcare in our Summer Reach program. Summer Reach ends tomorrow. It was 25 sites and for us, and then we, again, starting July 13th and running through tomorrow, July 31st. And then of course, our school-age childcare, where we had multiple sites as well. So that's been our firsthand experience in Hamilton County Schools thus far.
That's good to hear.
Right, our next question is, when a student has COVID-related symptoms, is there anything to ensure that the student has been tested or that they, well, this question is, I'll finish the question, but it's more for our team, or that they completed the quarantine period. So if we have a student that has COVID-related symptoms, is there anything to ensure that the student has been tested?
Yeah, so we're working on some guidance. I know that Cheryl Fletcher, our nursing lead for the district, has been doing some training of nurses. If a student obviously tests positive, there are some steps that the health department's probably better speak to that. In the case they test positive, there's some steps that they'll have to take through them. From the standpoint of being symptomatic, we'll have guidance that we'll release on that later tomorrow about anybody that's symptomatic.
Yeah, we'll obviously be involved in the contact tracing and the case follow up, and then obviously if they have a private physician, they'll be involved too. But we've tracked the isolation periods very closely, and then document that with a letter. So that should be very much discernible exactly when those times are.
And our next question is regarding the transition considerations. Are those numbers the hospitalizations, ICU, and average daily positives 7-day rolling averages, or something else?
We look at how many are currently hospitalized from our perspective.
In terms of the data on the health department side now, on the daily cases, we have a 5-day average on the graph of daily cases, and that's obviously even more useful than the daily, because it gives you, ease out some of those spikes that Dr. Woods was talking about earlier in the data. We don't routinely put out averages on some of the other data, but that could be done. That would just be someone smarter than me could figure out how to do that, I'm sure.
And from the school, Hamilton County Schools, we look at a 7-day average on our trends.
Right. The next question is, there's a bit of discrepancy between the number of active cases that the state reports for Hamilton County versus the number of active cases that the local health department reports. Why is that?
Well, the data comes to us, the state, at different times, and then obviously has to be entered in and then put on to graphs. That those gaps have actually gotten much better recently, but generally the data is going to come to us first and then go to the state. So for the most part, the data we have and we publish is going to be more accurate and more up to date than the states, because most of the time it gets put into the state database by us, by the health department. Now, some will go straight to the state and to us. So that kind of works both ways. But that's why, looking at the data on a day-to-day basis can be very confusing and at times misleading. And it really is better to look at those 7-day averages and all. As the whole data process has been a real adventure with this and getting it all put together, because we're tracking lots and lots and lots and lots of cases all over the state. We have data coming in from out of state. If a Tennessee resident gets tested out of state, and making sure that the data is accurate. So it's hard to get those totally coordinated. But as a general rule, the data we post on the website is going to be much more current.
Yeah, I looked at both sites earlier today, and the difference in count were 35 cases out of 5,400 or something along those lines. So not a significant difference.
Right. Our next question is similar to a healthcare environment. We have some staff like therapists and psychologists that work in close proximity with students. So what are your recommendations for handling that?
Well, Steve?
Yeah, so those decisions have to be made on an individual basis. One of the questions that came up in front of the school board is, are you going to make every single kid wear a mask in every situation? And that's where there has to be some leniency. So if you have a child who lip reads, it would be cruel to have their teacher wearing a mask all the time. And likewise, if you have an autistic child with sensory issues, good luck in getting a mask on that child 100% of the time. So those are situations that we'll deal with on an individual basis, and we'll work with the school system and the teachers to find a way to mitigate the risk and at the same time provide services.
Yes, and certainly along those lines, in some situations, although there's some evidence that face masks, clear face shields, especially those that wrap around, work pretty well. But the CDC hasn't recommended the routine use of just face shields without a mask at this point. But there are times where that may be the answer, especially the wraparound type for a teacher in certain situations, and maybe for some children, if they can tolerate that as well, but not a mask. So again, I think these things will be case by case basis, trying to do as best we can. So we can keep as many children getting what they need as much as they can.
Right. Our next question is, with flu season on its way, are the symptoms similar to COVID-19? If so, is there a test in place to divert the two?
Well, flu will probably come at some point. I will tell you there's some, I guess, information coming out of Australia where they are in their winter and they typically have their flu season this time of year. And I think they have been locked down a lot more, and they're not seeing much flu yet by report. So the same measures we take with masks and schools being closed, things like that. Also, we've known for 50 years or more that you can really put a big dent in a flu, the seasonal flu outbreaks if schools close for a bit. So we're seeing that there. So depending on how much we're open or closed on various circumstances may also affect when the flu shows up and how widespread it is. Unfortunately, there is a lot of overlap between flu symptoms or the symptoms that you get with the flu and some COVID cases. A lot of kids with both will just have what looks like a common cold, but we also know with COVID SARS-2, you can get muscle aches and fever-like or flu-like symptoms that you just can't tell apart clinically. We do have rapid influenza tests that are available in a lot of settings. So sometimes those can be done to try to help distinguish. in near real time. Unfortunately, we also have a lot of studies from different countries, including the US, that you can have COVID, SARS-2, along with other respiratory viral infections, including the flu. So you can have co-infections at times, and that may make it harder. So we'll be doing a lot based on just symptomatic exclusion. So if you are sick, it doesn't matter the cause, you should be at home.
I can tell you too, this is another good reason to get your flu shots, get them early, because that is one less thing you'll have to worry about. So if you ever had any doubt about getting a flu shot, this would be the year to get rid of those doubts, because that's be one less thing for you to worry about.
All right, our next question is, are face shields an acceptable alternative to face masks?
Well, I guess having sort of touched on that a minute ago, I was hoping we might be there where they really could be. And I think the CDC guidance prefers the face masks at this point, but there again will be situations where a face shield will be the way to go to facilitate the best service to that child while protecting the child and the teacher. So there will be times where face masks, face shields, and especially those that provide a good wraparound to the side of the face may be usable, but they're an alternative rather than first line, I guess, at this point.
Yeah, I think
Jenny,
that's fair.
this is Keith. I might just say one of the things we're doing is also ordering a substantial number of the masks that have the clear opening in front, just to ensure that what we're trying to do is prepare for all options. So,
And honestly, there is concern about droplets getting into the eyes, and no one can argue with also protecting the face with face shields. But I agree with Dr. Woods that they shouldn't substitute, except in those circumstances where the mouth needs to be visible or there's some other reason you can't wear a mask.
And I will say, in the healthcare settings, when we are around patients with COVID-19 in the regular floor units as well as the ICUs, the physicians and nurses and other staff are wearing eye protection as well as masks.
All right, our next question is, why aren't temperature checks a requirement?
So we tried that in the hospital setting, and we ultimately moved away from it for a couple reasons. The first one was, if you're going to use an oral thermometer, which is the most accurate, you've got to acquire a huge number of covers for them, and it takes a significant amount of time to test each person. So you can imagine having a big line at each entrance, which is exactly what you don't want to have. The second reason is you can be horribly infectious and not have fever. So it gives a false sense of security that, oh, well, I didn't have a fever, I'm fine. It was something that was initially recommended, and I think people are moving away from it. It's just not practical.
Well, and the devices, every device or test that we have has some degree of false positive rates or results and false negative results. And these infrared measuring devices on the forehead, sometimes, that's not always, that skin temperature on our foreheads does not always equate to what our core body temperature is, which is what we're using to measure whether you have fever or not. And so the accuracy also is a bit suspect. And sometimes we would have a false positive and put people through a whole lot of misery or deny them entry when they're fine. And other times we actually miss it and someone shouldn't be coming in. So it's important really to hopefully rely on people's honesty about, do you feel bad or not? Because you usually don't feel well when you have a fever. And sometimes that if we can work from that point, if you feel bad, then let's take your temperature, but maybe do it orally to get an accurate reading and decide if that's what's going on.
Okay, our next question is, what qualifies as an exposure to someone who has tested positive?
like a contact.
More like what are the specifications? What would you consider, like in a school, if there was someone who was positive, what are you looking at to say that that person came in contact with someone who was positive and needs to be quarantined?
There's kind of a formal definition of within 6 feet for more than 10 minutes. So you start from there. Obviously, anyone who's been within 6 feet of that person for more than 10 minutes is going to be a contact. And that's kind of the official definition we use. But you've got someone who's been a little bit farther for a longer period of time, or a little closer for a shorter period of time. There's a little bit of judgment that has to be taken into effect there. But, when you've got kids in a classroom and they've all been there for a period of time, then it's probably a good chance that they're all going to be considered contacts, at least in that classroom. But that's just hard to predict in advance.
All right, our next question is, how often are we seeing symptoms in children that test positive?
That's a great question, and it's hard to actually know the exact proportion that are asymptomatic entirely for their whole course, and versus those that have some symptoms. I'm thinking it's somewhere between 30 and 50% maybe are asymptomatic or minimally symptomatic. Some may have just a little bit of runny nose, and they don't even think they're sick, and just keep moving on through life. So it is significant, especially in younger children, and their disease is usually milder than in adolescents and adults. And certainly as you increase in age, it seems the proportion that are more ill becomes or increases. So it's a bit of a moving target based on studies, yet we know there are asymptomatic children, and there are a substantial proportion, but a lot of children will have some minor symptoms. Most will just have some degree of cold and sometimes a flu-like illness.
Okay, our next question is, how long should a school building be closed after there's a positive case?
Long enough to clean it. And we've built time into the plan, and ultimately that will become an operational decision. And maybe it's longer than what we've built in, maybe it's shorter, but enough to disinfect the surfaces.
And the only thing I would add to that is a couple of things, just as far as steps since the reopening task force. One of the things that came out of the work with the reopening task force was that we were going to need to acquire some additional custodial support and services to address just the general proactive steps that need to be taken in addition to the rapid response steps if there is a positive case. And so we have gone about that, and we'll have additional custodial support that's there. And actually, and just in full disclosure, I mean, we're getting this answer consistently, just to let folks behind the curtain a little bit of what we're doing. Keith and Colonel Brooks and some other members of our team were on a call earlier today with Park Ridge as they've kind of dealt with, as all hospitals have dealt with actually sick patients that have COVID. And we asked this question explicitly, and Dr. Adams got the same response, long enough to clean it. And so that's that. We feel like, not being medical experts, when we defer to medical experts and those that are dealing with the operations of hospitals, et cetera, just know that we're looking in their direction to gain insight, to glean from lessons learned as we look at reopening school. I know, Keith, you may have something to add, or Dr. Woods or Dr. Hendricks.
Keith, I think you're on mute.
3 times today. I always, as we, I think it goes back to what we said earlier about the plan and the framework we're working in. As we learn more, and it's not just, we're just not relying on our task force members. We're You know, like today we had the meeting with one of the hospitals here in town. We're reaching out consistently to other school districts, to industry, to just really kind of understand what they're doing. And as those lessons are pertinent and that we can bring them back and incorporate them into what we're doing, that's the steps that we're taking.
Okay, we're at 6:30 now, so we're out of time. I don't want to hold you guys any longer, but I know there were a lot of questions that weren't medical that we didn't have a chance to get to, and I'm going to we have a reopening email address that you can send those questions to, and we have a team of people that is reviewing that inbox and answering your questions, so you can send your questions there. I don't know, if Dr. Johnson, do you want to close us out and thanking our special guest?
No, just one more time. Can't say enough about Dr. Adams, Dr. Woods, Dr. Hendricks, how appreciative we are that you've made yourselves available really throughout this process. Candidly, our entire medical community has been just phenomenally giving in regards to helping us, and just from the lessons they've learned and the expertise that they have. Know that we are dealing, and I always reiterate those three points. We're dealing with a very fluid situation that will require and has required us to give parents a ton of choice, and we think that's of extreme importance. But then also, we hope that as we embark, just as we did in the spring, and you all did in the spring as a community, that we have grace as we deal with this unprecedented moment in time, and we will absolutely get through this together. I'm so confident in our teachers and leaders and our students, and just excited in whatever modality we're in to get school started on August the 12th. And we look forward to the start of the 2020-2021 school year. So thank you again for spending time with us this evening. And again, thank you, Dr. Woods and Adams and Hendricks.
Dr. Johnson, may I give one very, very brief sermonette before I leave? And that is for the parents out there who are on this and staff and everything. I think it's really important to remember that obviously you're focusing on the schools and what happens in the schools, but the schools aren't in plastic bubbles. And a big part of the advice on making it safe for schools is making it safe in the community. So this is why it's so critically important for everyone out in the community to continue the same kind of precautions that we're talking about in the schools. If the virus is not going to show up in the school on its own, it'll be brought in by someone from out in the community. So the more we can do out in the community to be safe, wear your masks when you're in public, keep your distance, stay home as much as possible, do all the things that we've been hammering on for the last few months. The more we can make our community safe, the more we can make our schools safe. So thank you for the opportunity to be here.
Thank you. Thank you.
So, all right, thanks, bye.